This is the second case. Comparatively, an old RD, uh, not very old as the look says. After doing the PVD induction and meticulous base dissection, we made a retinotomy in the nasal side, and we can see the thick fluid coming out. Along with it, a surprising thing happened. You can see the retina got splitted. There was tension retinotomies all over the retina. In all quadrants of the retina got splitted. This was a very unusual finding, which I never saw in my career. In last 15 years, I've never experienced such a situation that retina gets splitting everywhere. And actually with the tension retinotomies, the retina settled well. You can see there's a multiple breaks in the superior part. And then we had to do a laser in all the retinotomies, tension retinotomies. Might be this was due to an atrophic and old retina detachment, and putting in buccal might have prevented. The third case, this was a macular hole. It started as a simple macular hole, and while peeling, I realized this macular hole is quite large and conventional peeling might not work. So that time it was quite, it was late to plan an inverse peel because I have already peeled around the ILM around the macular hole. So what I thought, I will put an free flap. I'll do a free flap technique for this macular hole. So try to stuff in the ILM inside the macular hole. Although the ILM was quite large enough, so I thought I will trim it. For the time being, let me put it inside the macular hole. Then later on, I will trim it. But as there was no planning, actually, I had put 2 valve cannulas and another one was non-valve. So as I removed the instrument, there was a loss of it. So obviously, it took a very long time to ultimately repose the flap under PFCL. So a proper planning before the surgery is very important. We could prevent the loss of flap by putting some PFCL and placing the ILM under PFCL, using valve cannulas only, or using a chandelier and stabilizing the ILM with a forceps and keeping the incision temperature low. And this was another case, which is my last case. This is a very high myopic presented to the macular hole, comparatively simple case. But the problem is that no instrument was actually reaching the ILM level. You can see with the finesse, I thought I will raise a flap and then I will peel with the ILM peeling forceps. But after numerous tries, removing the cannula, placing the cannula more horizontally also, nothing actually helped. Ultimately, I had to proceed with the finesse loop. In the total ILM peeling was done through the finesse loop, which actually I don't use in any cases. But here, actually, this was the instrument which saved the, helped in managing this macular hole in a high myopic patient. And you can see we are peeling the ILM with a finesse loop. Sorry for the video because it was so high myopic when I was pressing, it was getting defocused. So however, I do the ILM peeling and ultimately the hole was closed through some unconventional method. So the take home message, any complication irrespective of nature and extent can be resolved through patience and definitely timely management. So thank you for patient hearing.